Woo! Hey! I'm not sure it's that kind of a meeting. Dear friends, colleagues, fellow patients, members of the Scientific Advisory Board, participants, carers, everybody. Welcome to the 4th European Pulmonary Fibrosis Federation Summit in the 2026. Hey, I'm going to split the screen with Alba. So Alba and I are going to use the next 30 minutes to give you a small tour. Let's start with the voice of the pulmonary fibrosis patients in Europe, as we always say. And let's start with setting the scene again. Not everybody knows who we are and why we are and what we are. So let's start by talking a bit about that. We bring together 23 member organizations from 18 different countries in Europe. And where people start asking me, where are you located? And I say, in Europe. Yeah, and they say, where in Europe? And I say, we have postal address in Brussels. We have secretariat in Barcelona. We have board members for true pan-European board members, which none of them lives here. So basically, we're a true pan-European organization. Thank you for all the member organizations. We are here for you. Okay, about us, we were established in 2016. Even though my math is not superb, even I can see that this is our 10th anniversary this year. So we're going to have a 10th anniversary dinner tomorrow to celebrate this. I'm not going to read all the text. You can do that on your own time later, and we are a little bit behind schedule. But our aim is to defend the rights of patients, and that means also the right of the carers, because the carers are just as important as the patients, and we often refer to them as the forgotten patient. Our mission is to be a trusted resource, both of information and also how to reach out and connect the dots. I'll get a little bit back to that later. Our goal, promoting access to accurate and unbiased information on pulmonary fibrosis care. This is getting more and more important in today's world of artificial intelligence, where anybody can ask a bot, how do I treat what I got and what do I do with it? Fostering collaboration with scientific experts and medical societies. I'm very happy that we have so many of our scientific advisory board members here today. And this is crashing with their professional league, the ERS, their summit. They have their spring meeting this weekend. So basically, we have a representative there who will join us tomorrow, Liam. And most of our scientific advisory board is at that meeting. So for those of you who decided to come to us instead of attending that meeting, that makes us extremely proud, so thank you. Supporting the establishment of patient advocacy groups in countries where there is no representation, advocating for the rights of people living with PF and their carers, promoting meaningful patient involvement in key healthcare systems. That's also why the Swedish delegation is not here, because they have their arms full with the new report and a lot of patient advocacy work back in Sweden. So basically they decided that they'll come next time. Facilitating information exchange and collaboration between Europeans, because doctors are good. Everybody's good, but they're within their own bubble. Involving access to treatment and services across Europe. The board of directors, which are all here, I am the serving president. Together, we will present you. Chantal, please stand. Chantal is the secretary. She's Belgian. Radistina, Radostina is here. Steve from Bulgaria. Steve, I see you. Well, you see more of him. Steve's from the UK. And Stefano, there you are. Stefano from Italy. And Liam, which is serving our duty at the ERS spring meeting, so he'll join us tomorrow. And Meltem from Turkey, which unfortunately has not been able to come yet. Okay, how we work. Okay, now you've seen, we're all patients or carers in the board. That means we cannot do everything. That means we constructed several committees which reporting to the board, because then we can involve a lot more people, and they will take each of their responsibilities, present to the board, so that the board can be informed and make the right decisions based on quality information provided by quality people. So we have a research committee headed by Steve Jones. We have a policy and advocacy committee headed by Liam. I'll come a little bit back to that later because we're working a lot with policy and advocacy. Governance committee, which is headed by Chantal, and the finance committee, which is headed by Stefano. Alba, which you will meet later, and we serve on all the different committees, so that's why our names are not here. But that is a valuable instrument for both the board and the administration to carry this forward. And then we have the most important ones, the executive teams. You will meet them as they go here. Alba, please stand, Alba. They'll see you later. It's Reshe. Anna, I can see you in the back. Anna is here. We got Linda. Is Linda here? Yes, you are. Events director. And we got Gergely. Who is Gergely here? Yeah. Yes, Gergely is here. He has an important role of policy advisor. That means he is translating all of that administrative or complex governance and policy work, which is done by the EU, which is done by a lot of other organizations. He's our voice within that community and translate also the information coming back to us. And then we have Sarah. Sarah, you here? Yes, Sarah is in the back on communications. So they are running the show on a daily basis. And there are only a couple of them living in the same country, so that's why we say we're true pan-European also in that respect. Okay, we've been working for the last decade. It's not almost a decade, it is a decade. Within policy and advocacy, research, capacity building, patient summit, and campaign, and awareness campaign, of course. You will hear much more about that going forward. Then, okay. I got 2 slides, very short. Become a bubble burster. This is one of my theses, because we are working, everybody, my theory is that everybody is within their bubble. You have the healthcare professionals, you have the patient and carers, you have pharma and medtech. Everybody is working within their bubble and understanding the world according to their bubble. Let's try, we can, as I say, patients live and feel the disease, carers know the patient and the impact of their disease, healthcare professionals are dedicated to treating the disease, and pharma, medtech, and HCPs are working to solve the mysteries of the disease and finding new treatments. Now I soon need oxygen. It's only when bursting the bubbles, enabling the sharing of unique knowledge from each group that we may see a true patient-science symbiosis, creating possible dream teams for the future. It's serious, and that's what I want you to have in back on your mind, that we engage with the different bubbles and burst bubbles, so we start sharing information. And next, you will only receive high-quality information during the next couple of days, which is important. This is a digital landfill that we call the internet. The hard thing to do is find the golden nuggets. Finding information is not hard. Finding quality information and knowledge information might be harder. Remember that everybody has an agenda, you just need to find out which one. Information has always a fresh date, like fresh food, a sell-by date. Find out if it's expired or not, because on the internet it will say they're closed for forever. Social media are full of experts, some qualified, but most are highly unqualified in that respect. And with those words, I will say welcome and hand the chair over to Alba. Thank you.
Thank you, John. And again, I want to have the words from John. Welcome to Brussels. But as well, I want to say welcome to those of you joining us online from anywhere where you are. We have more than 280 people registered online, and we will have them participate actively today. The title of the slide is housekeeping, because chaos is not in the agenda, or if it's chaos, the idea is that you don't see it. So that's what we are here to explain to you. There you go. First of all, I want to say thank you to the working group that has been supporting the Secretariat to organize this summit. So we had John, Chantal, Jean-Michel, Stefano, and Tom. They have been fundamental to designing the agenda and the whole summit together with the executive team. So thank you again for all your time, for all the meetings, and all the feedback. Just a bit of housekeeping on the translation. If you are here on site and you have the headsets, these are the channels. And if you have any problems, please let us know and we can help with that. And if you have as well the headset and you want to hear to the English channel, that's a possibility as well. For those of you online, you can hear the translations. As you know, we're going to have French, German, Dutch, Italian, Greek, and Spanish. The only thing you need to do is go into the browser on Swapcard, click on the headset symbol, and select the language that you want to use. If you have any issues, you can reach on the chat, and my colleague Natasha, who's managing Swapcard, will be able to help you online. Again, Swapcard. This is how we stay connected. This is how we engage, not only within the online attendees, but as well with you here on site. We're going to have some opportunities to either network, you can connect to other attendees, you can see the agenda, you can register for the workshops, and you're going to be able to then participate on the polls. We're going to do a quick test on this. So I'm asking you, if you don't have the app on your phone, please download it, because that way you will be able to participate with some of the interactions that we have planned over the days for the sessions. For those of you online, how do you ask questions? So we have on the bottom of your screen, you'll have a button called Live Interaction. There you have the chat, the questions, and the polls. The chat is more for comments, greetings, etc. But when we get to the Q&A, you need to put the questions on the questions section. If a question has already been asked, you can vote. You can promote it so we know that one is of interest for most of you. If you're in the room and you don't want to ask questions out loud when we get to the Q&A, you can post them as well on Swapcard. They will be reviewed, and we will do the best to make sure that all the questions are answered. And then there's the polls section. When it comes to the Q&As, there's a couple of things we want to ask you. Keep your interventions short and relevant to the topic. Try to avoid to have any personal or medical information on those questions. We always encourage and ask for a respectful dialogue. We all have diverse opinions, and those diverse opinions are welcome, but we do want to do it in a respectful way. And we ask you as well to please listen, make sure that the question has not been already answered in the past. Okay, let's do a quick test. See who has downloaded the Swapcard as well for our online attendees. So if you would go to Swapcard and to the opening session, and you will be able to access the poll that my colleague Natasha has already launched. And we just want to ask you a very simple question. What are you hoping to take away from this summit? Practical insights, new connections, strategic inspiration, or if you are on site and you just came for the food. That's valid point as well. And on that one, I want to say thank you, Raslin, for reviewing our menus and making sure they are suitable for the pulmonary fibrosis patients. I'll give you a couple of minutes to answer the poll. There's only one valid option. And then we'll get the results on screen in a second. And this is how you do a live test. It's coming. I can see the ABT moving in the back, so it's happening. I'll take the time to say thank you to our translators in French, Dutch, and German who are sitting in the back of the room upstairs, and to the AV team as well. And if not, we'll look at the results later. Okay. And we need to close the poll, Natasha. And it's in French, so someone can translate this for me. So basically, 50% of you are looking for inspiration and information, and then good practices. And no one came for the food. I mean, come on. We should have higher expectations on that. Okay, that's good to know. Can we go back to the slides, please? Okay, now what you really, really want to know is, if you don't know yet the program, what are we going to do over the next 3 days? So we are going to have a range of sessions that have been tailored specific to our audience. And there's 2 types of sessions. As you know, we're going to have the sessions that happen here in the plenary in the Silver Hall, which are the ones that are being streamed online. And then we have the workshops, which are the ones that you have with the red sign, where you need registration. If you haven't registered, please do it through the Swapcard app or ask us in the information desk, because we have limited seats available. After this, I'm going to hand over to Steve Jones, Maria Molina, and Helen Parfrey, where we're going to be talking about science in action. And then we're going to have a workshop on tackling inequalities in PF care. And have as well a session back on the Silver Hall on living well before and after transplant, followed by an industry symposium. And we will wrap up with a networking reception will take place here in the building on the 5th floor. Tomorrow is a long day, but we have make sure there's enough breaks and enough time for each of you to have a bit of a relaxed time. So we're going to talk about policy, we're going to talk about best practices across Europe, we're going to talk about genetics and innovations. We're going to have a workshop on closing care gaps across the ILD spectrum. Then we're going to have 2 sessions for specifically targeted for the local community, one in French and one in Dutch. Then we're going to talk about drug pricing and reimbursement and why should the patient community care about this. And we will wrap up the day with a workshop to discuss about caregivers and how we support them, and then a final session on early diagnosis and prevention. Sorry. As John mentioned, 2026 is the 10th anniversary of EU PFF, so we are going to celebrate with a 10th anniversary dinner. If you haven't registered, there is still some opportunities available, so you can reach out to us on the information desk. You will be able to come to the information desk to collect your ticket for the dinner, so please do that after any time on the coffee breaks today and tomorrow. And we're going to have a shuttle bus leaving at 7:25 p.m. from Motel 1 to take you to the event, which is Tricoterie. And remember to wear the blue. It's not a gala dinner. We just want you to wear something blue to symbolize organization. What am I wearing? Blue? Me puedo bajar el micro. Me puedo bajar el micro. Oops. Also, I had the microphone here all the time. Thank you. And Sunday, short day, we're trying to finish the summit, so we're gonna have 2 short mini symposiums. This is something new we're having this year. And we're gonna have 2 big sessions, one on shared decision making, which is something that we haven't discussed yet in any of the previous summits. And then we're gonna have a closing ceremony to wrap up with the conclusions of what we have learned over the past few days, how we can strengthen the PF community. And something that we're trying to achieve here is, yes, we're having all these sessions, we're having all of discussions, but what next? So what is the UPFF and what is the pulmonary fibrosis community gonna do with all the discussions and everything that happens in this room? And that's it. It's a full agenda, but we hope that you can enjoy it, especially as well for those of you online, not only on site. We have posters. There's a couple of posters still missing, but we have posters just outside the auditorium, and there's actually some awards. So we encourage you to go through the posters during your coffee breaks, and there's voting papers, so you can, give your feedback, and that's going to be awarded at the closing ceremony. I think John already did the introductions, but if you need anything over the course of the next 3 days, here's the team. Anyone with, I don't have a red badge that says staff will be able to help you. And we are here to make sure that you enjoy, learn, and take as much as possible with you. We want to thank you, our sponsors, for their support. Without them, this wouldn't be possible. And we hope that you all have a good time. So what I'm going to say, sit back, connect with people, network, and enjoy the summit. Thank you very much for joining us. Now, we're going to give the floor to Steve, Maria, and Helen for our Science in Action session.
Okay, great. Hi, thank you very much for having us here. This is the first session, Science in Action, Innovations in Pulmonary Fibrosis Treatment. We've done this session or something like it in each of the last 3 summits, and this is the first one that I come to it feeling really excited. In the last 2 years, we now have a new drug, nerandomilast, that's achieved its primary endpoints and has been approved by FDA. It's in use in the States, and we hope it'll be in use in UK and Europe soon. We have the 2 TETON 1 and TETON 2 trials, which have also achieved phase 3 endpoints, a little bit behind nerandomilast, but hopefully coming through the system and hopefully will also be approved. We have another BMS LPA1 antagonist in phase 3, fingers crossed for that as well. So we've really got a situation of hope, which we haven't had on the previous occasions. This opens up, there's so much work going on in understanding the microbiology of fibrosis, understanding genetics, there's so much going on that we're looking forward now to the day when we will have personalized medicine, when we will be able to have specific treatment packages for different patients of different types, and ultimately we will be able to stop this disease. And I'll ask each of you at the end how long that's going to take. Okay, so we're very pleased today to have 2 colleagues with us. Helen Parfrey from Royal Papworth Hospital in Cambridge, a respiratory physician there, and also an affiliated professor at the University of Cambridge. I've been with us in EUPFF, been with APF since the very beginning, and also EUPFF since the very beginning. And Maria Molina from Barcelona has also been with us since the beginning. In the UPFF, was involved in the original drafting of the patient charter and various other notable things in our history that you'll hear a little bit about over dinner tomorrow night. So Maria is, I'm going to get this right, the ILD lead at the Belviche University Hospital. Not bad? Okay, good. And also academic lead at the University of Barcelona in ILD. So as I understand it, Maria is going to talk first, mainly but not exclusively about IPF, And then Helen's going to talk afterwards mainly, but not exclusively, about PPF. And then each speaker will talk for about 20 minutes, and then that will give us a good time for Q&A. We're going to start off with the people online. So all of you online, I know you often feel isolated at meetings like this. Your questions are going to come on first, and then we'll turn to the audience after that. So great pleasure to introduce Maria Molina and invite her to talk.
Thank you very much, Steve. I have to say that it's a great pleasure to participate in this type of sessions. I guess that this is why we are working in ILD, you, the patients. And I guess that we enjoy a lot exchanging this type of overviews and also trying to maintain our motivation. So thank you very much for the invitation, and these are my conflicts of interest. For the next minutes, I love the title, Science in Action, but I thought that it was not good to explain you what is behind everything in terms of pathogenesis and basic research and everything, only some details about how we arrived now to the antifibrotic era. So you already know that we are treating IPF with antifibrotic drugs. We have 2 in the market, but these 2 antifibrotic drugs arrived just in the last 15 years. And coming from the last 22 years, because it was in 2002 when the hypothesis of the IPF pathogenetically was accepted. And then, from then to now, there were an improvement of knowledge that arrived to improve the treatment. So this was in 2002, but in 2022, there was another achievement in the clinical guidelines. For us, the clinical guidelines are good because we can go to the administration and tell them, this is quality of our healthcare. If we don't follow these guidelines, we are not doing some good healthcare. So in these 2022 guidelines, the comprehensive therapeutic approach of IPF is already included. So it's a strong effort to enable this integral approach in terms of treatment to all of you. And then in 2025, as Steve mentioned it, the beginning of the combination of the antifibrotic treatment. Why? Because with one antifibrotic drug, we can slow down disease progression, but we can't stop disease. So our main goal is to stop disease. Our next goal is to reverse disease, but the first one is to stop disease. Okay, so I told you that I won't be in depth in all these complex pathogenesis that it is the cause of your disease, but only telling you that these 2 drugs in monotherapy have in common that they affect or they are inhibiting different pathways of the pulmonary fibrosis. And probably that's why they showed beneficial effect in FVC decline, because it's not only acting on one way, it's acting in different ways. And the other picture that I have to show you to retain in your mind is that we have this monotherapy, we have the 2 new drugs that will be in combination with the monotherapy, but furthermore, we have many new drugs in clinical trials, some of them already in phase 3 clinical trials, in phase 3 stage, which means that probably some of them will come to stay with us for new options for monotherapy and also for combining. Probably in the future, 2 or 3 antifibrotic drugs will be available for stopping. Remember the goal, stop the disease. So only some important remarks about the clinical trial that was performed for nerandomilast, which is one of the drugs, of these 2 drugs that will come in the next months or in the next year. In this clinical trial, more than 1,000 IPF patients in 3 different arms, 2 different doses, 9 milligrams twice a day and 18 milligrams twice a day, oral dose, versus placebo. And I have to say that this drug, what it's doing is increasing the CMP, which is in the cell, and then it's antifibrotic. But the important thing is that it's complementary to the action that is doing pirfenidone and nintedanib. So in this clinical trial, the beneficial effect of nerandomilast in monotherapy with no background therapy or in combination with nintedanib and pirfenidone was positive, as you can see here in the global, but here with no background therapy, you can see both doses are effective. With nintedanib on top of nintedanib, also both doses effective, and I have to say that with pirfenidone, only 18 milligrams twice a day was effective. This is very important for the future when we are doing the combination in the real-world clinical practice. Because if you are taking pirfenidone only with 18 milligrams of nerandomilast, you will have a good effect. Why? Because both drugs may interact. And this was positive in the different subgroups of patients, which is consistent with positive effect. And the second antifibrotic drug is inhaled treprostinil. As you can see here, this drug was previously used in pulmonary hypertension, but then, due to this effect in the pulmonary hypertension associated with pulmonary fibrosis that was positive, it was the first antihypertensive drug that was positive, improving the 6-minute walking test in patients with pulmonary hypertension associated with fibrotic ILDs. So in this clinical trial was very important, not only because this positive effect in the primary endpoint, but also to this secondary endpoint, which was the FVC. There was no enough number of patients and also no enough number of months evaluated to achieve any type of significant effect, but you can see this trend to more stable FVC in these groups. So this was the reason to go for a clinical trial, a phase 3 clinical trial for IPF. And there is a TETON-2 performed in different countries, including Europe and Latin America, and TETON-1 mainly for US and Canada. For 52 weeks, this time 1 year, FVC higher than 45% predicted, which is good because it means that almost all IPF patients may be included. And with a titration of this drug, this is an inhaled drug that starts 3 breaths every 6 hours, and then increasing the dose up to 12 breaths every 6 hours. We try to manage the night and reducing the hours between the doses to sleep 8 hours. So don't worry, we won't reduce the quality of the night for you, but with these doses, the endpoint was positive. So the objective of the clinical trial was positive in demonstrating an effect, a positive effect, reducing the decrease of FVC. As you may see here in blue is the treatment arm, and here the placebo arm. And the placebo was with a standard of care. No background therapy, nintedanib, or pirfenidone again. Analyzed by subgroups, the consistency was again positive. In all the subgroups, the positive effect was maintained. And then we have some other interesting results. In this case, the clinical worsening or the timeline until the clinical worsening was better in those patients that were taking inhaled treprostinil significantly, as you can see here. And an important thing, the first time that there is some effect on quality of life. I guess that this is very important because this difference was based on the effect on dyspnea. So it's the first time that an antifibrotic drug also shows us an effect, a positive effect, reducing the quantity of dyspnea or the severity of dyspnea. And another important thing for us and for you, with a good safety profile, which means that for nerandomilast, the main reason for discontinuation was diarrhea, but in a percentage very low compared to nintedanib. And in case of inhaled treprostinil, the main reason for discontinuation was cough. I have to say that the percentage here is not higher than 20% when we compare the adverse events with the placebo arm. So, until now, we have these options, monotherapy. When we are worsening, we have the option of combination. It was not until now that was possible, so it's a new hope. And then we have a third option that is the clinical trials with new antifibrotic drugs that we can combine. How the clinical trials will evolve in terms of standard of care, we will see. It will be a complexity. But at least in our center, we have 4 clinical trials recruiting patients. So every year, we have more and more options for our patients. And finally, precision medicine. You know that some of you are coming from medical family history of pulmonary fibrosis. It's not frequent, it's very infrequent, but it is happening that potential genetic cause is behind this predisposition of pulmonary fibrosis. And one of the main evaluated genetic factors is telomere abnormalities. And there are some clinical trials specifically focused on patients with IPF that present these genetic abnormalities, which means that in these cases may stop completely the disease, or this is the main objective. And even in the future, if there is some effect with these treatments in this specific subgroup of patients, it could be helpful even for the descendants before having progression of the disease or before having limitations due to the disease. But everything is not pharmacological. And I have to say that with this comprehensive approach, the patients were great in terms of capacity of exercise, capacity or the abilities of the daily life things. The emotional state as well, to me, it's a very important thing. We have 3 times per year the Nordic Marcha or any type of physical activity outside the hospital. One of the main improvements in the questionnaire is the emotional part. What's the relationship between the physical performance and the emotional part? I don't know. But what is clear is that we are trying to improve the physical state, but we are also doing a better improvement for the emotional part as well. Probably because people is talking, there is another atmosphere, and I guess it's a very, very good achievement. Then we have also the nutritional facts. I have to say that we are advancing more and more in terms of nutrition, especially with the worse effect of some drugs, such as pirfenidone, with saturated fat acids. So we are understanding better how you could be better adherent to these antifibrotic drugs. So, and the other point is the anti-reflux. Now we know that the anti-reflux problem that many of you are suffering is not treated with the proton pump inhibitors. The proton pump inhibitors are doing a good thing for reducing the acidity of the gastroesophageal reflux. But if we want to act on the gastroesophageal reflux, then we have to perform the different physical issues and nutritional facts for reducing this reflux. And little by little, these habits are more implemented everywhere, and it's not expensive. Finally, some comorbidities, pulmonary hypertension. We have inhaled treprostinil, but also we have other drugs trying to reduce this pulmonary hypertension or acting on this pulmonary hypertension that is a huge comorbidity that increases the mortality in IPF. And finally, the cough. What about the cough? For many years, more than 10 years, I remember here in Brussels in 2012, still before the federation, but working together from the patient association from the different countries, one of the main complaints was how to control the cough, because it was very annoying to perform the daily life activities. So we had the typical things, low-dose morphine, some types of sweets that could reduce the intensity of the cough. But now we have even drugs trying to reduce the cough, and Nalbuphine had a very good result or achievement in the phase 2b, and now they will start the phase 3 in the next months. And only in 6 weeks is able to reduce the severity of cough with a statistically significant effect. So I guess that, as Steve said, it's a moment for hope, but not because we say it's a moment for hope. It is because there is a lot of advancing behind. Thank you very much.
Thank you. Thank you very much indeed, Maria. Helen, welcome you to the stage. Thank you.
Great. Well, thank you, everybody, for asking me to come and participate in this seminar, because it is a very exciting time in pulmonary fibrosis. And I'm going to talk a little bit about the changes that have been happening in progressive pulmonary fibrosis. So these are just my disclosures. So we've recognized in many of our patient groups that if you don't have idiopathic pulmonary fibrosis, you can still have scarring in the lung that gets worse over time. And we were very limited in how best to treat this because we didn't really have any evidence base, as had been shown for patients with idiopathic pulmonary fibrosis. So as clinicians, we were concerned that we weren't giving these patients the best treatment. And we recognize from many studies that having progressive pulmonary fibrosis has an outcome that's very similar to idiopathic pulmonary fibrosis. And that's just what this chart shows here. So this is looking at patient survival. The red line is those with IPF, and the blue line here are those patients who have progressive pulmonary fibrosis that's not IPF. And you can see that these are absolutely similar. We also recognize that actually these patients with progressive pulmonary fibrosis comes from having many underlying diseases. Lots of it's related to problems with their immune system, like rheumatoid arthritis and lupus and systemic sclerosis, but it also happens with conditions like hypersensitivity pneumonitis and sarcoidosis. So there was a large group of people who weren't getting best treatment. So as Maria's already identified, one of the major changes that's helped us to make sure patients get effective and appropriate therapies was the introduction of these guidelines in 2022 that for the first time in the title, as you can see here, included not only idiopathic pulmonary fibrosis, but also progressive pulmonary fibrosis. And there has been sort of the background to recognizing how these treatment works actually came from small studies in groups of people who had fibrotic lung disease that wasn't idiopathic pulmonary fibrosis. And one of these was looked at in a cohort of patients with systemic sclerosis. And they had fibrosis. It wasn't necessarily progressing, but they certainly had fibrotic lung disease. And the study suggested that if you added in nintedanib in addition to the treatment that they were getting for their systemic sclerosis and their lung disease as part of that, so their immunosuppression, that there was an additional benefit. And what we could see is that how quickly their lung function declined was basically halved over a year by adding in the antifibrotic therapy. And you can see how this is very similar to what was reported with the idiopathic pulmonary fibrosis trials. We saw similar side effects, particularly with diarrhea and nausea, but generally the treatments were tolerated and in combination with the immunosuppression. So if it works in patients with systemic sclerosis, we should then look in other patients with progressive pulmonary fibrosis. And that's where the InBuild study came from. And so they took a much larger group of patients with many different types of progressive pulmonary fibrosis. And they defined these patients as having progressive disease. And they defined it in a number of ways. They already had to have scarring or fibrosis on the scan of the lungs. And then they could fall into one of these three groups. They could have the lung function getting worse by more than 10%, or a combination of the lung function getting worse as well as worsening symptoms and more scarring on the scan, or a combination of worsening symptoms and more scarring on the scan. And you can see that most of the patients fell into these sort of two definitions of progressive fibrosis. They were all given oral nintedanib over a year, and what the study showed is that those patients on nintedanib had a much better outcome in terms of slowing the rate that the disease got worse compared to those on the placebo group. And as you've seen, that this is very much like what we were seeing with the idiopathic pulmonary fibrosis trials. And not only did it help to slow progression, when we looked at other risks that can happen for people with fibrotic lung disease, we saw that these treatments helped to slow patients being admitted to hospital or reduce the risk of patients being to hospital because of worsening of their lung disease as it can occur with an acute exacerbation. And these treatments were then approved by not only the FDA, but by the European and the UK medicines, and became standard of care therapy for patients with progressive pulmonary fibrosis. Similar studies have looked at with pirfenidone. Again, this is a very small study in systemic sclerosis called the LOTUS study. And what they did with this, they just gave treatment for a short period of time, just for 16 weeks. And they wanted to know, was it safe to give it in combination to people who were already on immunosuppressive therapy for their systemic sclerosis? So they weren't really looking for change in lung function, but whether it was safe and if patients could tolerate it. And they observed that those two outcomes were met. Larger studies looked at pirfenidone in a group of patients with rheumatoid arthritis-associated lung disease. Again, these weren't patients who necessarily had progressive fibrosis, but had a fibrotic component to their interstitial lung disease. And this study, unfortunately, hit the time when COVID happened and the pandemic, and it interfered with many of the clinical trials that we were taking part in. So although it didn't reach the primary endpoint of the study, it showed that being on pirfenidone slowed the rate of decline in your FVC in a manner that was similar to that seen in the IPF studies. And that's what this figure shows here, is that patients on treatment, their FVC reduced by 66 mils compared to those who weren't on treatment at 146 mils. So in the UK, this treatment unfortunately wasn't approved for us to use for progressive pulmonary fibrosis, but that differs across different countries around the world as to how they use it. And the reason I mention that is because now how we treat autoimmune disease-related ILD has recently been developed by European guidelines from the rheumatology associations around the world, and they're actually recommending pirfenidone for the treatment of rheumatoid arthritis-related ILD. Another study looked at pirfenidone in other causes of progressive pulmonary fibrosis, and this was the RELIEF study. And again, unfortunately, this was hampered by the pandemic, which led to a very slow recruitment in the study. So again, the study didn't meet its primary endpoint, but it showed that there was a trend that the treating patients with pirfenidone helped to slow down the rate that the pulmonary fibrosis progressed in these patients. So what about our new drug that we're just waiting for our European and the UK licensing authorities to approve for us? Well, this is nerandomilast in the FIBRONEER studies. And like the IPF studies, this was given to patients who had progressive pulmonary fibrosis. Now, these patients were mainly on background nintedanib and not pirfenidone in this study. And as we can see here, that being on the treatment, whether the 18 milligram twice daily dose or the 9 milligram twice daily dose, had a slowing in the rate of decline of the lung function compared to those who were not on treatment. And you can see this demonstrated here, that these slowing the progression is very similar to what we've seen with the idiopathic pulmonary fibrosis studies. And similarly, being on treatment helps to reduce the risk of further events like hospitalizations and exacerbations of pulmonary fibrosis. So we too in the UK are going through NICE approval so that we will soon be able to use this in combination with our current antifibrotics for patients with progressive pulmonary fibrosis. So what is coming next? Well, these are some of the clinical trials that you've heard a little bit about in IPF, because they're now realizing that there's many similarities between progressive pulmonary fibrosis and IPF, and so we should be trying these therapies in all of these conditions. So there is the MIST study, which is looking at nebulized pirfenidone in patients who are already on treatments like nintedanib for their progressive pulmonary fibrosis. There's been some data released recently from the company showing that in their earlier studies, this treatment is effective at slowing the FVC decline, and so we're hoping that that will be the same for those patients with progressive pulmonary fibrosis. There is the BMS studies, which have already been alluded to, and this on their phase 2 studies in progressive pulmonary fibrosis, we can see that being on the treatment helps to slow the decline. And so this is now a much larger phase 3 study that we're taking part in, and many centers are around the world looking to see if this too is going to be another successful therapy for progressive pulmonary fibrosis. And then the other one that we've already heard a lot about is the TETON studies, and this is the phase 3 study that is going on looking at inhaled treprostinil for progressive pulmonary fibrosis. So this is really exciting because it looks like combination therapies may be not only potential for IPF, but also other forms of progressive pulmonary fibrosis. And I just wanted to think about why all of these developments have come to light, because it's taken us 10 years to get a new therapy for pulmonary fibrosis. And I think one of the key things that has happened is that we've changed some of the approaches that we've used to study and understand mechanisms of pulmonary fibrosis. And I've just shown some examples of these techniques here. So one of the things that we can now do is actually grow out the epithelial cells. These are the cells that line the airways and the air sacs, the alveoli of the lungs. We can grow these out from patient samples and actually culture them in little Petri dishes and make what's called an organoid. And it's a bit like how we're trying to mimic how your little air sacs, your alveoli are working. And we can use those to then add in other cells or to test compounds, new therapies, to see whether they're going to be effective at treating the condition. Similarly, the people are now taking sections of the fibrotic lung, which I've shown here. This is what the fibrosis occurs in the lungs, and using those in models where you take very thin slices of the lung and you put them in an air-liquid interface to mimic what the lung would look like. Because we breathe in air, and our lungs have a little bit of lining fluid that sits in our air sacs to help the cells work properly. So you can mimic that in a little chamber, and then you can then injure these or expose these to either viruses or toxic chemicals that may cause fibrosis, and also for testing the effects of some therapies. So these have helped us think about pulmonary fibrosis in a different way. There's also lots of new technologies, means that we can sequence DNA and RNA from many of these cells to know a lot more about their function and how they behave. And so there's been big advances in how we think about the mechanisms of pulmonary fibrosis. And so we put together this sort of little schematic picture here to try and show you that it's a balance of all of your exposures that we get throughout our life, through some risk factors that we may have, some of those genetics, but by far one of the biggest risk factors is that we all get old, and that's something we can't stop. And it's how that these factors interact, not only to affect the cells that line the air sacs, the alveoli, but also the blood vessels around here, and then affecting the cells in the immune system that get recruited to these sites of injury. And as we've already alluded to, because there are many different mechanisms here, there are many need for therapies to target many of these pathways. So we're never going to be one treatment for pulmonary fibrosis. We're going to need combinations to target different bits. And just in the last few minutes, I want to give you an insight of some of the things that may be coming for the future, because I think this is really exciting for us. To develop a drug costs drug companies billions of pounds, euros, dollars to take it, and also a very long period of time, maybe 10 or 15 years. We've got lots of new developments, particularly artificial intelligence, that is leaching into all of our lives and how we work. And this is playing an important role in medicine, not only from analysing X-rays and CT scans that are being built in now to clinical trials as a way of assessing if the treatments are working by looking at changes of scans, but people are using it in very innovative ways. And one of this is actually using artificial intelligence to try and identify novel therapies. Now, this is just one example in the world of pulmonary fibrosis. So what this company did, or this group of researchers, is that they looked at all of the available data in the public domains that have been published on mechanisms of pulmonary fibrosis, analysis of all the single cells from the lungs, and put all of that data together and analysed it using artificial intelligence to try and find targets for treating pulmonary fibrosis. They found a number of targets, and they looked to see could they see these in animal models of pulmonary fibrosis, and they identified that they were there as well. So one particular target that they identified was a kinase, and they've called it TNIC. So this is a kinase that regulates cell turnover, but also regulates a lot of inflammatory processes in the lungs. So they identified this using artificial intelligence. They then used artificial intelligence to design or find an inhibitor for this kinase. And they identified this drug. And this drug is called rentasertib. I'm sorry, none of them have easy names to pronounce, do they? And what they found, and this is in an animal model of pulmonary fibrosis, that if they use this compound in an animal model of pulmonary fibrosis, it reversed the fibrosis or reduced the fibrosis. So they then took it into clinical trials. They used in healthy volunteers and in a small group of patients, and it looked and appeared to be safe. So this is the phase 2 data in a group of about 120 patients with pulmonary fibrosis. And they compared it to a placebo, which is this group here, and then 3 different doses of the treatment. And this is looking at the change in the FVC with this therapy. So those on placebo and the low dose, you can see there's no real difference in the FVC decline. But in those patients who were on the higher dose, the FVC didn't decline, and we actually start to see the FVC increase. Now, it's hard to know exactly what this means, but it's quite exciting because all of this development happened over 30 months. So they've reduced the time it takes to get drugs into this level of phase of trials, which is also much more economically viable as well. So I think this is an exciting area, and I suspect we will see a lot more developments with this over time. The other area that I think is also very exciting is how we utilize and understand the immune system response in pulmonary fibrosis. We know our immune system is there to help us fight infections, but it also helps us fight things like cancers. And in cancer treatments, that's been harnessed for using immunotherapies as a way of treating cancer. So a group of researchers wanted to see if they could use this to try and treat pulmonary fibrosis. So what they did is that they did a massive undertaking to try and find peptides or little proteins that are expressed on cells that gets shown to your immune system. So our immune system consists of white blood cells called particularly T cells that are very important to making a response to when we have an infection or even cancer, and they're sort of master regulators of that. So they use this technique called immunopeptidome to try and identify peptides or proteins in fibrosis that were being expressed to these T cells. They identified many targets, and they, through a variety of selection processes, identified 3 of these that they then used to make a vaccine. So they incorporated these peptides into a vaccine and gave this in an animal model of pulmonary fibrosis. So they then vaccinated these animals and exposed them to the things that cause pulmonary fibrosis. And they found that these animals then didn't develop the same level of pulmonary fibrosis. And what their results suggest that by using this vaccine approach, you can harness the immune system to fight the cells that are involved in developing fibrosis. So your own immune cells, your own T cells actually target and clear, can remove, kill, if you like, these very active fibroblasts that are involved in pulmonary fibrosis. This has only been done in animal models so far, but I think it's a really interesting concept because this is what cancer biology has been developing over many years. And I think it's a field that I'm sure we're going to learn a lot more about in chronic conditions like pulmonary fibrosis. So I'm just going to finish now by just saying, between our 2 talks, we've shown you that in the last 20 years, but particularly the last 15 years, there's been major advances in how we treat pulmonary fibrosis that have improved patients' survival living with this condition. But we want more. We want to stop fibrosis, and actually what we really want is to reverse fibrosis. And I think some of the new technologies that we have are helping us to actually realize that these are probably going to be more achievable than we thought. And in the meantime, we've got better therapies for treating pulmonary fibrosis, but also therapies that are helping to treat the symptoms that have previously been very difficult for us to manage. So thank you very much for listening, and I will finish there, and I think we should hopefully have lots of good discussion about some of these concepts. So thank you very much.
Well, thank you very much indeed, Helen and Maria, before. Well, we had a comprehensive tour of the landscape at the moment. I didn't know about the last bit. This is completely new to me, which is great. I mean, I believe Gisli's written a paper called about vaccinating for PF.
Yeah, so it's a very recent...
Oh, sorry.
Sorry. Yes, yeah. So the last study I just discussed about how we can harness our immune system with vaccines to fight fibrosis is a very recent study. So I think there's an editorial that Gisli has written about this as being as a potential newer approaches for how we manage pulmonary fibrosis.
So who knows what the next generation will be able to benefit from. It's great. Do we have any questions online, Natasha? You're waving. No questions online yet. Anybody in the floor would like to come with a question? We've got microphones ready, I think. No question is too silly. I know what it feels like in these circles. Jean-Michel down the front here, and then Eleni next to. Thank you.
Thank you a lot for the tour of all the clinical trials. It's giving us a lot of hope, so that's clear. But we are still dying too much from pulmonary fibrosis. You didn't talk about early treatment, and do you have data about it? Because we are observing that generally when people are treated late, they are
Sorry,
doing
Jean-Michel,
much.
could you hold it a little bit further away, maybe?
Yeah, it's better like that?
Yeah, I think so.
Yeah.
Yeah.
Do you have data about that, about the efficiency of early treatment or not with all these drugs, in fact?
Yeah, this is an incredible question because I guess that until now there is no still evidence regarding the early treatment, but it's evidence about the delay of diagnosis and treatment that is associated with shorter survival. So despite there is no evidence, it's clear that in the last year there is a huge effort to identify earlier, to treat earlier. But there is now a clinical trial that will identify in familial forms without symptoms if starting nerandomilast for 2 years is better than wait and see. So I guess that this will give us a lot of information about what to do in cases in which we are able to identify soon in terms of subclinical, no functional decline, but fibrotic ILD, especially IPF in the context of familial forms, for example. And I guess that little by little in our clinical practice we are treating before. Why? Because we know that with antifibrotic treatment together with the comprehensive approach of acting on acting on the reflux or many other things that the patient may suffer that may worsening the disease. So if we treat those things that may impact on the progression of the disease, probably we will have a better effect. So 15 years ago it was impossible, or 10 years ago it was impossible because we have no option for early diagnosis. But currently we have many programs for early identification, and it means that then we have a window of treatment when the patient did not reduce pulmonary function, neither have a decrease of quality of life. So probably there we will be able to stop the disease and with no clinical impact. And that I guess that we have to go to this early treatment.
Great. So the earlier you can treat, the more lung you can protect.
Exactly.
Yeah.
We have to work on creating the evidence, the research evidence, because until now there is no research evidence in favor of this. No. But in our clinical practice, I guess that we are observing this tendency, and we will be able to demonstrate in the next years, probably.
I mean, could I ask another question? One thing that came out, certainly with nintedanib, was whether it extends life or not. And I believe now with nerandomilast, that question's being asked as well. What do you think the evidence is on that?
Yeah, I think none of the clinical trials have sort of prolonging life as an outcome because it would take too long to be able to get those results. So, and you'd need such large numbers of patients to recruit, so that it just becomes unfeasible to do it. So a lot of the data now about the effects on how these drugs are affecting survival has come from studying people who've been on them for a long period of time through registries around the country and around the world. And, you know, we do see that actually being on treatment does prolong life, but there is a huge variation in an individual's response to treatment. And that's the difficulty here, is that we don't at the moment have anything that we can use in the clinic to say this is going to be the best treatment for you, but also this is how your disease is likely to change over time. So we need some, you know, the biomarkers, if you like, that we use for that are actually change in lung function or change on your CT scan. But that's too late, because by the time that's happened, you've lost 10% of your lung function or 10% more fibrosis on a scan. So we need something that is more sensitive. So that's part of the role why people are using AI to look at more subtle changes on CT scans so that we can use that. And then there is a huge amount of work looking at potential biomarkers that we can have as a blood test to use in the clinic. Because as more and more treatments become available, as a clinicians, we won't know how to use them in combination for people. And what we don't want to do is give people lots of side effects while we're trying to work out what is the best combination of treatment for you. So we really need good biomarkers to show that the treatments are being effective. And I think that sort of leads on to, you know, we've talked about studying families. In the UK now, we're doing a big lung cancer screening program, and we're picking up patients who have very early changes of interstitial lung disease of some description on their scan. And so somewhere between 5 and 10% of people who are being screened for lung cancer have these abnormalities on their scan. And we don't know what to do with them because we don't know whether they are going to progress or not. We don't have the capacity in the clinics to see all of these people, and we don't know how long we have to monitor them for. So we really need some biomarkers that are going to tell us, you've got these changes, it's not going to do very much, go away and have a lovely life, you don't need any of these these treatments that it's just not required. Whereas actually we need to treat you now to prevent this from getting worse. So that's the area that we really need to be working on.
Great, thank you. Great question, Jean-Michel, thank you. Please, Eleni.
I want to ask, I think that I want to stand up because
Please stand up.
Jean-Michel is taller than me, so I'm taller now.
I have the same problem.
Yes, I want to ask simple questions that I had from COVID patients in Greece and with all patients I'm discussing. Now we have two medical, Nitatamab and Pirfenidone, and I want to know how our doctors decide which medicine we will take and why we take this or the other one. This is my first question. The next one, I don't stop usually, says Jean-Michel.
Yeah, we have noticed, yeah.
The second is, I hear all these hopeful things from you, and it's very hopefully all this situation. The new medicines, Neramilasta, all the other one, I don't remember the name, but I have to ask if as patient will take it together, we can take it together with our previous medicine, Nintedanib or the Neramilasta. All we have to decide one of them. And I don't know what will be happen in the healthcare system if they can give us two antifibrotics medicines. This is the second one. If we can take it together, if we have to do it. I don't understand it in the beginning. And the three one.
Oh no,
is,
third is what we got.
The three one. Just a minute. It's very impressive. The thing about the vaccination, and I want to ask. I'm warning how we will go in this stage if we don't know what is the cause of the disease. What is that cause? PF. I don't know. It's a question for you. Thank you.
So who would like to tackle the choice of which drug for a patient to take, when to take them together and things, yeah?
So I suspect this is probably similar to how doctors in many different countries do this, but we have a conversation with the patient about their lifestyle, their other health problems, to try and help work out which drug would be best suited for them, because they're both equally effective at slowing the rate of progression. So it's not that one drug slows it more than the other. They just work in different ways, so they have slightly different side effects. And so we work out which one we think would be best suited for somebody to take the drug, depending upon their health conditions. With nintedanib, we have to be careful about people who've got very bad heart disease and aneurysms and things, because there's a potential risk it can be harmful there. Whereas with pirfenidone, we can't use it if people's kidneys don't work very well. So those kind of things are thought about when we're trying to decide which treatment to have. In England, we have another slight level of complexity, because NICE, who decide how we can use these therapies, also give us stipulations about what level of FVC we're able to use for treating these drugs. So that may differ on a country-by-country basis, but we usually have a discussion with people to work out what drug we think is going to best suit them, depending upon their lifestyle and their health conditions.
The new one with nerandomilast, when the decision gets made about whether you can take nerandomilast or whether you have to first prove the nintedanib doesn't work, or whether you can mix them together to get that extra little benefit.
I mean, we're hoping this, because obviously we don't know what we're going to get, is that we should be able to use it as an add-on therapy to people whose disease is progressing despite the current therapy that they're on. So that's what we're hoping. There will be some people who can't tolerate either drug. And at the moment, if you can't tolerate pirfenidone or nintedanib, the only choice we can offer is a clinical trial, provided you're suitable for that clinical trial. Because as you know, if any of you have taken part in studies, the criteria for going into the study is often very narrow, and it doesn't apply to all people. So we're hoping that if you can't tolerate either pirfenidone or nintedanib, we'll then be able to use nerandomilast as a treatment, as a single agent treatment as well. So that's what we're hoping, and I'm sure that's probably what Maria's hoping for as well. But in the UK and England, we just don't know until NICE give us guidance.
Probably depends country by country, but I completely agree with Helen about the empowerment of the patients for deciding, depending on the potential effects of the drugs in terms of monotherapy, for deciding between pirfenidone and nintedanib. I have to say that in both drugs has no patent now, which means that the price reduced a lot.
Yes.
90% in some countries. So, which it makes easier to combine a second drug. So I guess that once the European agency and the country-by-country approval arrives, the inclusion of the combination will be faster than we thought 1 year ago, probably, because in terms of price, as I said, the reduction of 80–90% of the price will help a lot. This is the first thing. And the second thing is that we need to understand the adverse events as well, the potential adverse events. Up to 20% of our cases with IPF or PPF are not tolerating the drugs that are in the market right now. Some of them tolerate it at the beginning and not later, after years. So I guess that one important thing is that once you are not tolerating nintedanib, neither pirfenidone, you have a third or fourth option to have as monotherapy. So the important thing is not having, so important is to have all patients with fibrotic ILDs or with PPF and IPF under treatment. And then escalating, ideally would be depending on the biomarkers, but we have no biomarkers at all. So I guess that we have to understand as medical doctors the pathogenesis and what we are inhibiting. And also we need to understand what is the patient doing usually. For example, in Spain, many patients are, from now until October, they go to the beach. So with pirfenidone, for example, we have photosensitivity. It's the only drug that may produce photosensitivity. So then if the patient, if the patient is living near the sea, and with this effect, you can choose first nintedanib. If the patient has some diarrhea, then you can try with nerandomilast or inhaled treprostinil, for example. The type of combination will be very interesting because we have to remember that inhaled treprostinil has also an effect on pulmonary hypertension. So in a minority of cases, pulmonary hypertension may appear from the beginning of the diagnosis of pulmonary fibrosis. So maybe this could be an interesting profile of patient to start this drug, but we will see because we have to conduct registries and produce more evidence to give you a good answer.
Okay, am I correct in thinking that you've got, with nerandomilast, we expect that the reduction in the slowing down of the fibrosis will be at least as good as nintedanib from the results, but with the benefit will be it won't give us so many side effects. So at the moment, many people give up nintedanib, and they maybe have it only for 2 years of their 5 years of living with pulmonary fibrosis because they can't take it. The big advantage of nerandomilast is you may be able to take it for 5 years, and that will give you benefits for 5 years instead of just for 2 years. Is that right? Yeah.
Yeah, and I think it's going to be really important to monitor people on these treatments so that we get real world evidence and data to know how they're tolerated and what effect they're going to have on long-term survival. Yeah.
All of us who have been on nintedanib know how much we love it. Gurgley. Oh, sorry, over here first. John, yeah.
Yeah, a short question. There was something, thank you, both of you, for wonderful presentations. And I'm very excited. One question. Maria, something you said in your presentations around artificial intelligence. What impact do you think that will have on the time frame of both drug development and not only drug development, but the approval process of new drugs?
I guess that artificial intelligence arrived to be here, but we need to better understand how to use it. This is Helen showed these advances in the timeline that we spend between identifying a drug and then arriving to the phase 1-2 clinical trials. I guess it's an important achievement, but it's important to understand that the persons behind the artificial intelligence are very important. The persons that are using this artificial intelligence are the clue for identifying the proper answers, because the result, in part, may be important due to the question that you are asking to the artificial intelligence and also the data you are including to the artificial intelligence. But it's true that for diagnosing in terms of artificial intelligence for CT scans and for reading automatically the CT scans, and second, for treatments, it will represent to faster improve the situation or the scenario of pulmonary fibrosis. I have no doubt.
Great, thank you. And Gurgley next, yeah?
Yes, actually the pipeline is unquestionably promising. I was wondering how you envisage the treatment algorithm or strategy in a near future. Do you think that upfront combination therapy with step-by-step descaling might be a gold standard as it happens in pulmonary hypertension, for instance?
Yeah, I guess that in the future we will, probably in IPF will be first, starting by combination probably, because in the nerandomilast clinical trial for IPF, you had one criteria was not progressing, so you could have a patient with IPF and nintedanib stable, and including the patient in the clinical trial. So probably it will start first with IPF, and probably due to the financial cost, probably we will start on top one monotherapy, the second line, and the third line probably in the future. but we need to have better knowledge about safety and also what is the best option, because there is no comparison between the different potential options and the different potential profiles of patients as well. So I have to remember that this pipeline, probably we forgot to say that this pipeline that is incredible comes from the huge effort that all of you as patient representative performed many, many years ago in the European Commission for Orphan Drugs. It is due because the effort of the patients and the patient representatives in the European Commission to push in favor of investing in rare diseases. And it's due to the benefits that the European Commission set for orphan drugs, for rare diseases, due to you. So I guess that it's something that we forgot to say, but since 2012,
Yes.
more or less, I remember this huge effort, and in 2016, the ERN started, and also all the benefits for the orphan drugs. So I guess that having this hope is also part of your work.
Yeah. Patient power. Yeah? Good. Yeah. Back of the room, and then Stefano. Need that microphone.
First, I have online meetings with IPF patients, and what I can hear here is that there are very similar conditions for PFF and IPF. Can I include the PFF patients in my meetings? What we are talking about is conditions, emotions, relatives. Relatives are also a part of the meetings. So can I include PFF in these discussions? I'm a patient, I'm not a doctor.
So I think yes is the answer, is an easy answer to that question, because a lot of the challenges that people with IPF have and their carers have are exactly the same that people living with progressive pulmonary fibrosis face as well. So I think the shared learning between these groups of patients is really important and benefits them definitely. Yeah.
I think that's absolutely right. We've made a conscious effort in EUPFF and also in Action for Pulmonary Fibrosis, my home organisation in the UK, about 7 or 8 years ago, to really make sure we weren't just talking about IPF. I remember Helen once saying in a meeting, it's in the name, stupid, you know, Action for Pulmonary Fibrosis. It's not just about IPF. And the reason for that is that we all experience it the same way. You may have rheumatoid arthritis, ILD. You will have problems I don't have as an IPF patient, but we share the same breathlessness pathway, and we share probably to some extent cough as well, the same fatigue. So we experience it very similarly. So it's really important that we see ourselves as a community, I think. Yeah. Stefano, sorry. Could we have a microphone here? Oh, sorry. Okay, Tom.
Yeah,
then
Steve.
Stefano next, okay?
Yeah, thanks, Steve. Two very quick questions. Tom McMillan here, Pulmonary Fibrosis NI. I listened with a lot of interest, and thanks very much for all the hard work that's gone on within research, and I think everyone in the room will agree it's very encouraging to hear what's going on. Something that you didn't say I would like to ask you, and that is, when can we start to see, do you think we can start to see nerandomilast being prescribed to patients in the UK? That's part one of my question. And part two is, when do you think we will ultimately see a cure or a slowing up of this disease for patients?
Okay, so for the UK, is my understanding is that NICE are reviewing it sort of September time, so the autumn. So we're hoping later this year we will have some response from NICE. There's been a lot of work put in for the submission to the NICE submission to try and make sure that this goes through, but as you know, with previous attempts, sometimes it doesn't go through the first time, and it may take a bit of time. It's unknown, I'm afraid, but it's certainly being reviewed at the end of September time as it's being reviewed. Yep.
What was the other question? Was there a second question, Tom? Did we? There was a second question right here. No. Can we have sorry? Can we go from this one to Stefano next? Here. Sorry. Oh, sorry, Stan. We'll come back to you. And then to Stan.
I think the second question was how long this is going to take. I think I used to tell people that I probably would have retired before this was going to happen, which obviously could be a long time. I think my take on it now is that we have new technologies that we are learning to use in a more effective way that will significantly impact what we do, and I think will reduce the time for developing these treatments and will identifying targets and treatments and getting them into clinical trials quicker. The question is how effective are these identified targets going to be in curing the therapy? And that's the unknown bit. So that's the bit that is hard to answer into that. So I think we're going to streamline the process, but it's whether we can find the holy grail as the right target.
Okay, we've got 6 minutes and 3 questions. Stefano.
Yes, another question about the cause of IPF. As in your opinion, it has already been stated that it's a list of different causes, or is still there is still some researcher who is trying to find a real or another possibility of a cause?
Great, thanks.
Yeah, it's a very tricky question. I have to split what is cause than pathogenesis. I guess that we need to understand that we know what is happening when the pulmonary fibrosis is worsening. So in terms of what is happening in this process, we know what is happening. And that's the clue for the antifibrotic drugs. But why or how it starts, the cause behind, we always say that it's a mixture between a genetic predisposition and environmental factors. Something is triggering the expression of genetics that abnormally repair the lung. But without a lesion or an injury of the lung, there is no requirement of repair. So, why we know it? Because there are from the familial forms of IPF that may be around 20% of IPF patients may have a familial form. We understood that there are some genetic predisposition very clear and identified that may be present in different members of the same family, and in one subject may develop the disease at 50s, another with 70s is not developing the disease, and another with 55 developing another type of ILD different than IPF. Which means that although the same genetic predisposition, depending on the environmental factors or the exposures, the development may be different. So until 10 years ago, we had no idea about this. I guess that now we know better what is impacting, and there is a lot of research behind trying to better understand what is impacting in the expression of genetics. And once we know it, we will be able to stop it, or even to prevent it for the next generations.
Fantastic, thank you. That's great. Stan, welcome from Chicago.
All right. Well, so I'm Scott Stasek, the CEO of the Pulmonary Fibrosis Foundation in the U.S. So a couple things. I don't really have a question, just a couple comments. First of all, we've had nerandomilast approved in the U.S., but it's been a very short window of time. And obviously the healthcare system in the U.S. is so different. But what we're seeing is that sometimes patients are able to get a prescription for combo therapy with not a lot of problem. And then sometimes some insurance payers want to try one of the generic formulations first and show that the patient has failed on that therapy for whatever reason before going to a branded therapy. But it's quite a unique situation in the United States, even from state to state, on what the pathway is. The main reason I wanted to respond was Jean-Michel asked the question about early study in diagnosis and treatment. So this is just launching right now, but the National Heart, Lung, Blood Institute in the United States, which is a subdivision of the NIH, is launching a program called Preempt PF. And I'm looking at my notes just to make sure I say this correctly, but it's pioneering research for early evaluation and mechanistic preemption of pulmonary fibrosis. I have the opportunity to meet with their staff quarterly, and this is going to be a multi-year study, and right now they're just looking for the scientific coordinating center for this study, but the intent is to look at early diagnosis and treatment options for patients. So stay tuned to that. I imagine the results of it. This will be a multi-year thing, 5-6 years or so, but they're going to be putting a significant amount of funding into this.
Thank you very much, Scott. You finished just as the red light is flashing down here. So, Lisa, I'm sorry, we'll come back next time. Thank you all very much indeed. Thanks very much to Helen and to Maria for a great talk.